So before I go in, can anybody try and give me a definition? What is dyspnea? I want to make sure we're all talking about the same thing. Can some courageous soul give me a definition of dyspnea?
Shortness of breath on exertion.
Okay, shortness of breath on exertion. Perfect. Anyone want to give a counterexample, or we all agree with that one?
Shortness of breath. I think out the exertion.
Okay, no, take out the exertion, just shortness of breath. Perfect. So that's absolutely a component of dyspnea. I think the one key piece that I want to make clear as far as the definition, and we'll talk about this at the end when we're summarizing everything, is it's a subjective feeling of shortness of breath or the inability to get enough air. So is dyspnea the same thing as a low oxygenation?
No.
No, absolutely not. So one key thing to keep in mind is just like pain, we're not going to talk about pain today, but that's really another core concept in palliative care. The only reliable measure for dyspnea is the patient's subjective report. We have other objective measures that can hint that our patient might be at risk for having dyspnea, but a low O2 sat or an increased respiratory rate or a bad arterial blood gas, none of these equate to dyspnea. They all hint that the patient might have dyspnea, but the only way to diagnose dyspnea and to gauge how we need to treat it is by asking the patient how they feel and if they're experiencing dyspnea. And we'll talk a little bit about the physiology of why it's subjective and why it's important to ask patients. And the prevalence, as I'm sure you all see, is incredibly common, especially for seriously ill patients. There's been studies to try and equate it in somewhere between 12% and 74%. So an easy way to think is probably about half of your seriously ill patients will experience dyspnea at some point. The pathophysiology of dyspnea. So what do you all think causes patients to feel dyspneic or short of breath?
PE.
PE, sure. So that could be a potential cause. What else? Or physiologically, what do we think causes that feeling of dyspnea?
Lung metastasis. Anemia.
I think two people spoke at once. I couldn't hear you.
Lung disease.
Lung disease. Okay, perfect. Well, anything else? A PE? Arrhythmia? Absolutely. So stepping sort of a little bit back from these are the sort of pathologic causes. Physiologically, what actually happens that causes patients to feel dyspneic? Did anybody remember any of these things from medical school? I have to sometimes review it because it's been a while for me. So remember hearing about oxygen chemoreceptors or baroreceptors or CO2 chemoreceptors, and then also mechanoreceptors. So the receptors in our muscles, in our face, various other nerves that all together give signals to the body to equate how much oxygen is available. Is it adequate for what's going on? Does any of that ring a bell? We're not going to go into detail, but it's important to remember there are a number of different monitoring systems all over the body that together make up that feeling that potentially tells the brain to feel dyspneic or not to feel dyspneic. So ultimately, so this is another key point. What leads to the brain and the patient experiencing dyspnea is not one or two of these specific receptors. It is the combination of all of them and what we call an afferent-efferent mismatch. That's sort of the fancy technical term. I think an easier way to describe it is when there is some sense in the body with the receptors, so either the oxygen level, the CO2 level, the stretch on the muscle receptors is telling the body it's not adequately breathing, then that your body will send a signal to the muscles in your diaphragm, in your lungs to try and breathe either harder or faster. Now what happens is if your body is able to close that loop and make the appropriate changes, the body does, or the brain doesn't necessarily feel dyspneic. That's why having a low O2 for a patient that has COPD for years, they don't feel that dyspneic when their O2 is 92%, whereas a perfectly healthy patient that has a sudden PE and their O2 is 94% feels horrendously dyspneic. It's because for the patient with COPD, over time, their body's been able to close that loop and the afferent-efferent signal are lined up. So there is not a mismatch, so the patient doesn't feel dyspneic. However, and here's just a little bit more, are you able to see that? I know the text might be a little small. So in this loop of the chemoreceptors, of the patient's effort, of the baroreceptors in the airway, of the muscle receptors that are in the chest wall, if those signals don't match up, so if one of either the chemoreceptors or baroreceptors is sending a signal that the body needs to breathe harder or faster, and then the body in the chest is unable to do it, either because there's pathology there, because they have fibrosis or an infection in their lungs, or if they're trying to keep up, but eventually the O2 level continues to fall or the CO2 level continues to increase, and this cycle is not able to close the loop, that leads to afferent-efferent mismatch, or a sort of a physiologic break in this loop, and that's what causes dyspnea. So the key point to take home is it's why any of these individual markers does not tell you if a patient's dyspneic. It's only if the cycle is somehow broken and that they're not able to adequately compensate. That's different than when we're looking at blood gases and talking about compensation. It's a similar concept, but here we're talking because it ultimately goes through their brains and through their central nervous system, is what ultimately causes that feeling of dyspnea. So again, here's just two examples to think about it. So you have a patient who becomes acutely hypoxic from maybe a small PE, but then very quickly their respiratory rate goes up, tells their diaphragm and their chest wall to breathe harder, and they're able to compensate and their O2 level stabilizes. They might not feel that dyspneic and it might not get worse. Whereas if it's a really bad PE and they're not able to keep up and the O2 continues to decrease, then they might have that subjective feeling of dyspnea. Another example would be, so if it's the actual muscle fibers and the lung tissue that's not able to expand the way that it's supposed to, and the body sends that signal to the brain, which then the brain tries to get the body to breathe faster, and if it's not able to keep up, again, that's an afferent-efferent mismatch, and then that can lead to a feeling of dyspnea. The last piece to keep in mind is this can also be psychologically mediated. It doesn't mean someone who's anxious automatically will become dyspneic just because they're anxious. It means if someone already has a slight afferent-efferent mismatch, and then that ultimately goes through their central nervous system and they have some anxiety or they become panicked, that can then make the dyspnea worse. So again, I would think of any psychologic components similarly to a baroreceptor, a chemoreceptor, or some lung pathology in the tissue, that it's all of these things together that if the cycle goes out of whack, that's what can ultimately lead to a patient feeling short of breath. Any questions so far about dyspnea? So I think, and then ultimately the impact of this can be immense, as I'm sure you've seen in many of your patients. So I think the key thing to take home from this first part, as far as the pathophysiology of dyspnea, is if you have one of your medical students who's rotating with you and said, oh, their O2's low, they must be short of breath. You can look at them and explain, well, they might be short of breath, but we're not sure if their body's compensating adequately or not. So we have to actually ask the patient. So ultimately, this all goes back to what we said at the beginning, that the appropriate diagnosis of dyspnea for palliative care purposes is you have to ask the patient if they're feeling short of breath and how severe their short of breath is. So then how do we ultimately assess it in order to come up with the treatment plan? It's a subjective assessment just like pain. So we will often, for patients that have severe dyspnea, we will use a 1 to 10 scale, just like we do with pain. So we'll say, oh, how bad's your shortness of breath today? They'll say it's a 3. We'll say, okay, what was it yesterday? It was a 5. Now we know it's improving. So you can absolutely use that as well. And we have these other indirect measures that we talked about, but never depend on these alone. You always need to ask the patient.